Okay, great. All right, welcome everybody once again to our 2016 Health Policy Seminar Series. I am Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research. It's my pleasure to introduce today's speaker and to welcome you to a timely discussion about a new law set to go into effect this June, which will make California one of only a handful of states to permit physician aid in dying, or the ability of a physician to assist a patient to end their own life. Before we move on to that topic, however, I just want to make an announcement about our next seminar, as I always do. Please save the date of June 13th for our special guest speaker, Dr. Lauren Gaze, who is the Chief of Health and Policy Assessment in the Division of Chronic Disease and Injury Prevention at the LA County Department of Public Health. Lauren will discuss findings from her recent article in the Journal of Experimental Criminology about a little discussed topic, the health and public health consequences of the juvenile justice system. Kind of a different subject for us here at the center. Specifically, she will examine the impact of teen courts, a popular juvenile justice diversion model in which youths are judged by their peers and given restorative sentences to complete during a period of supervision. Did this alternative justice solution prevent recidivism, which is linked to lifelong negative health consequences? Join us June 13th to find out. All right. And as always, we will be recording today's seminar, and it will be placed in our newsroom on our website at the address you see at the top of this slide. If you would like copies of today's presentation slides emailed to you, please send me an email at gdriscoll@ucla.edu, and I promise you my email does work. For those of you who had a problem, just try again. Please also note we will have a brief question and answer period at the end of today's seminar that I will moderate. And also please note we will be taking a break from our seminar series over the summer, the months of July and August, but we will be back in September probably with a spirited discussion of the presidential candidates' health plans. All right. Now on to today's seminar. In late 2015, California passed the End-of-Life Options Act, AB 15, which allows residents to end their life through physician aid in dying, or AID. In this June, implementation of the law will begin, yet there is little guidance as to how aid will be performed in the state. We are fortunate, therefore, to have with us today an expert who has looked closely at the lessons learned from the few other states that have passed aid laws. Cindy Cain, she's a new center faculty associate, and she's the author of a new center study on aid that was released today, and it's front and central on our website, www.healthpolicy.ucla.edu, so please check it out. In the study and in the seminar today, she looks at lessons learned from the implementation of aid in other states, as well as the ethical and practical concerns of AB 15 in California. She also outlined solutions that may help California policymakers, physicians, and health workers sensitively and comprehensively respond to constituents and patients. Cindy is an assistant professor in residence at the UCLA Fielding School of Public Health, where she specializes in quality of life issues for older adults. Before coming to UCLA, she was a postdoctoral research associate in the Division of Health Policy and Management at the University of Minnesota, in conjunction with the Division of Applied Research at Allina Health, where she participated in research on new interventions to support persons with serious illness, and she also conducted studies of various team-based approaches to care. Notably, Cindy's interest in improving care for older adults comes from her background as a hospice volunteer, where she saw firsthand how quality of life could be improved by creating person-centered care that focuses on mitigating unnecessary suffering. Cindy has a bachelor's degree in sociology from Indiana University and a master's and doctoral degrees in sociology from the University of Arizona. It's my great pleasure to welcome Dr. Cindy Cain.
Thank you. Well, thank you all for being here, and thank you to those of you who are able to tune in online. I hope today we'll be able to provide some clarity and some things to think about as we move forward with the End-of-Life Option Act here in California. So before we get started, I want to take just a moment to acknowledge the End of Life Option Act Research Group, which was established with support from Tom Weinberger to the Fielding School of Public Health, and he was able to help us put together a great group of scholars who represent a variety of different disciplines and perspectives, and they have been quite influential in setting the agenda for this research group. So I'll tell you a little bit more about what we're doing when we get to the end. So our agenda for today is to quickly describe the End of Life Option Act and some of the features that are most important for understanding what it means and how it compares to other similar laws. We'll place it in a national and a local context, and then I'll describe our analytical approach for coming to the findings that I'll be talking to you about today, and discuss the three main concerns that people have when they talk about aid in dying, and then review what data from other states tell us about those three concerns. I'll provide a few recommendations for how to improve the implementation of the End of Life Option Act in California, and then talk about the next steps of our research group and where we're headed in the future. So first, let's talk about the law itself. And so the End of Life Option Act, which was passed in October of 2015 and will go into effect on June 9th of this year, so just a couple of weeks from now, it permits aid in dying, which is a practice whereby a capable adult in the terminal stages of an illness can request a prescription that's meant to hasten their own death. So it's meant to give persons control over the timing and the circumstances of their death, and it's not legally considered suicide. So there are a few things that patients must do to make this request and receive the medications, and then there are things that physicians must do. So we'll go through each of those individually. So in terms of procedures for patients, they must be California residents, they must be adults, they must have a terminal illness that's expected to be fatal within 6 months. They make 2 oral requests separated by at least 15 days, and then they're required to make a written request, and there's this form that they fill out to make that written request. It must be witnessed by at least 2 people, and one of those people must not be a family member. So once you go through that process of making the oral request and then the written request, then the doctor can legally make a prescription. But other obligations for the patients is that there are no surrogate decision makers. So even if there's someone else, a spouse or a child or someone else in the person's life that can help make decisions in other contexts, they are not permitted to make the request for aid. And the patients must self-administer the medications themselves after completing a form that attests that they have self-administered. So in terms of obligations and responsibilities for physicians, their job is first to assess the capacity of the patients to choose freely and intentionally. They must inform patients of alternative options and discuss what to expect, whether the patient decides to opt in to aid in dying or not. They help get a second opinion from a consulting physician, and either one of those 2 physicians may request a mental health evaluation if there are concerns that an underlying psychological or psychiatric condition may be influencing decision making. After all of this, both physicians have paperwork to fill out. The attending physician documents everything in the medical record in terms of the conversations that they had, the diagnosis, the prognosis. But then there are also forms that they send in to the California Department of Public Health. So there's the written request form, a final attestation filled out by the patient themselves before they ingest the medication. The attending physician has a compliance checklist, and then the consulting physician also has a checklist and compliance form that they send in. And then after the person has died, regardless of if they used the medications or not, the physician fills in a final form that they send in. And so all of these forms go to the Department of Health, and they're collated, and once the law has been in effect for a year, the Department of Health will put out an aggregate report of all of these data. And so what we'll be talking about today from other states includes some of the data from those reports. All of these steps are meant to make sure the patient is fully competent, fully informed, and not subject to undue influence or coercion. And we'll talk a little bit about where those concerns come from in just a moment. So to really understand the End of Life Option Act, though, it's important to understand how it fits into a national landscape. So California is the 5th state to permit aid in dying. Oregon, Washington, and Vermont have very similar laws. Oregon was the first, Montana also permits aid in dying, but it happened through a state Supreme Court decision, and so there are fewer restrictions and no required data collection around this. So we know less about what happens in Montana than we do in some of these other states. And currently, several other states are considering similar laws in the next session, so we may see that this grows over the next couple of years. California's law is modeled after Oregon's Death with Dignity Act, which was passed in 1994 and went into effect in 1997. And it's also important to note that this change in the law comes at a time when there's national interest in end-of-life issues. There's been quite a bit of attention to issues of quality of life, choice, and empowerment for people as they face the end of their lives. This is shown through a couple of high-profile books that maybe some of you have read, including When Breath Becomes Air and Being Mortal. These are two books that have spent quite a bit of time on the bestseller list and talk about some of these issues, and also talk about some of the ways that in medicine, not only do we extend life, but sometimes we participate in also producing suffering for people. And so thinking about what some of the limits are of medical interventions. And this has really brought some of these issues to the forefront. Locally, there are also things that have happened that have helped to bring these types of issues into people's minds. So this is not the first time that California has tried to pass an aid in dying law. The other attempts had support, but they also had strong opposition. This particular attempt was passed through a special session on healthcare in 2015, and it was an opportunity to revisit some of these issues, especially after the case of Brittany Maynard became public. And she's a young woman who lived in California. She was 29 and was dying from brain cancer. And she made a very public decision to move to Oregon to take advantage of the Death with Dignity Act. And when that happened, as you can see, she was picked up on much of the local media and the national media. And so these types of conversations started to take place even more often. And some actually credit Brittany Maynard's very public decision as part of the reason that aid in dying became legal in California when it did. So these types of issues that came out in these discussions are still important. And so what we want to do today is talk a little bit about what we know from other states who have legalized aid in dying already. And so we went about gathering the information that we'll present today through a couple of different steps. First, we reviewed the literature on aid in dying across the United States. There's also quite an extensive literature internationally on aid in dying. And we have reviewed that as well, but our findings today are particular to findings from the US, and you'll see that in just a moment. We also synthesized the data from Oregon and Washington in particular, because they have the most data accumulated so far, to speak to some of the concerns. We'll show some of those data today. We synthesized it to determine what kinds of questions still exist, and then we put forward recommendations on how to improve California's implementation of the law. Through this process, we work closely with our work group, the End-of-Life Option Research Work Group, and we also worked with experts in the field to make sure we were able to put together a complete picture of what's happening and still be able to keep a neutral sort of position on this moving forward. We believe that's really important to understanding how California can improve implementation, is to really focus on what happens now that the law has gone into effect. So before we jump into what some of the issues are, I thought it would be helpful to give a basic background on the End-of-Life Option Act and how it fits within Oregon's data with the Death with Dignity Act. And so this graphic shows Oregon and Washington data. You see the Oregon lines start much earlier and extend to the end of the graphic. Washington is just the last several years. But there are a few things to point out. So the vertical axis is number of people. The horizontal axis is years. And you'll see that although the number of people who have taken advantage of the Death with Dignity Act in these two states has risen over this time period, the number is still very small. In fact, data just came out from Oregon for 2015, and 218 prescriptions were written total in Oregon in 2015, and 125 of those were used to hasten death. So that's still a very small proportion of deaths in Oregon. It comes out to be about 38 deaths per 10,000 in the state of Oregon. Second thing to notice is that in both states, there's a persistent gap between the number of people who receive the prescription and those who ultimately use it. Some people think this is because by having the prescription, it offers people an amount of control over the process that provides them with comfort, even if they ultimately decide not to use the prescription. It also may be the case that physicians are able to better meet the needs of people because they're having these conversations about a full range of end-of-life options. So the law states that physicians must make all other options clear to patients and let patients know that they can change their mind at any point in time, so they're not obligated to follow through even if they receive the prescription. Either way, we see that that gap exists between the number of people who receive and the people who actually use the prescriptions. In addition to giving an overview of what this looks like in practice, data can also help us to understand some of the concerns about aid in dying. So one of the most prominent concerns is that vulnerable persons will be encouraged to end their lives early when we pass laws, like the End-of-Life Option Act. So in this context, often vulnerability is defined as people who come from racial or ethnic minority groups, persons with low incomes or education, those with publicly funded insurance, or people with disabilities. Those are often the groups that you hear most talked about in these discussions. We don't currently have data on disability status or income, but we do have data in Oregon from those other characteristics. So here's a summary of some of those. So first of all, we see that over 97% of people who died after ingesting the medications in Oregon were white. That's in comparison to 77% of the Oregon population overall is white. And we know that California is more racially diverse than Oregon is, but we still expect that we'll see that whites disproportionately use this option as compared to people of color. Most people in Oregon who took advantage of the Death with Dignity Act have had at least some college, and over 46% have a college degree. That's in comparison to 30% of Oregonians overall who have a bachelor's degree. So we see that people who take advantage of the Death with Dignity Act are also disproportionately educated. And over 60% of people in Oregon had private insurance, and most others had Medicare or Medicaid. And we see that only 1.5% of people had no form of insurance at the time that they ingested the medications. So far, according to this definition of vulnerable persons, the data don't support the idea that the passing of aid in dying laws will disproportionately affect people of color. In fact, it may be the case that we have racial and ethnic disparities in terms of access to end-of-life options. So some have said this is because people of color are less likely to know the range of options, they're less likely to inquire about options, or they're more likely to have opposition to options that would hasten death or to forego any sort of curative treatments. This is in line with other disparities that we see at end of life, including hospice enrollment and palliative care uses. There are persistent racial and ethnic disparities there. So this is one area where we need to continue to do analysis and think about what the implications are of the particular demographics of people who are taking advantage of these laws. However, I also want to note that when we think about what makes a person vulnerable, there may be other definitions to vulnerability that we should consider. So for instance, one concern that has not been alleviated through the data is that persons with underlying psychiatric or psychological conditions may be vulnerable because those conditions are influencing their decision making. So that doesn't fall into our current definition of vulnerability, but it is a way that perhaps we should be thinking about vulnerability moving forward. The law is written to protect against this by permitting the physician, either the attending or the consulting, to request a mental health evaluation. But studies so far have shown that this is often difficult to fit into the schedule of treatment. Sometimes patients have resistance to this, and that even when those mental health evaluations are done, they are sometimes ineffective because it's very difficult for physicians to tell whether the underlying condition is influencing the decision making or not. So this is an area we need to continue to think through as well. The second concern that often comes up when people talk about aid in dying is that it will reduce use of palliative care services. So some people assume that when aid in dying is an option, physicians will be less likely to suggest palliative care and that patients will be less willing to try palliative care. However, studies in Oregon show that palliative care service spending and patient satisfaction with palliative care has risen since 1997 when the Death with Dignity Act went into effect. And so some of the reasons that are given in this literature is that physicians want to learn more about the range of end-of-life options when they sit down with patients and want to talk to them through those options. So they have an incentive to continue to learn. They also have an incentive to continue to learn how to have those conversations in a meaningful and person-centered way. And that also leads to spending more time with patients at end of life, so that actually it's not a replacement of palliative care, but that palliative care is improved through overall improvement in person-centered care. Studies have also showed that offering palliative care is an effective intervention to reduce the number of people who ultimately use aid in dying. So one study found that for people who had made a request and received a prescription, those who had had another palliative care intervention to control pain and suffering, 46% of those people decided not to ingest the medications. And that's as compared to 15% of people who did not receive another palliative care intervention. So there's a statistically significant difference between the people who received a palliative care intervention and those who did not, in terms of changing their minds about ingesting the medications. This suggests to me that we should be using palliative care in conjunction with aid in dying instead of thinking about them as replacements for one another. The data also showed that the vast majority of people in Oregon who ultimately ingest the medications were on hospice care at the time of their death. Over 90% of those people across that entire time period were enrolled in hospice. The final concern that people often talk about is that aid in dying will influence the practice of medicine itself, and that it's against physicians' professional code of ethics to participate in the hastening of death. Others are concerned that it puts a moral burden on physicians that may be harmful to the physicians themselves. And so the law provides for physicians to be able to opt out of the practice. There's no penalty for deciding not to participate in aid in dying. And opting out can mean that the physicians themselves decide not to prescribe medications, but it can also mean that physicians opt out of even providing information about aid in dying. So physicians can opt out entirely, or they may participate in providing information but not actually providing prescriptions. On one hand, that allows for individual physicians to be able to make decisions about how they would like to engage in this practice. But on the other hand, one thing that's missing is that it doesn't start to get at some of the concerns of the physicians who are not opposed to practicing, but have concerns about how that practice will take place. And so in our review of literature, we came up with some general categories of those concerns, and I'll go into specifics of what those concerns are now. So for physicians who plan to or do currently practice in aid in dying in Oregon, many of them are concerned about a lack of necessary knowledge. So for some of them, it's lack of knowledge about how to alleviate suffering. For some of them, it's a lack of knowledge about which medications to use and in which dosages. Many of the physicians talked about having a lack of knowledge about how to talk about end-of-life issues generally, not just aid in dying. Some were concerned about possible complications and how to protect against those complications or to support patients and their family members if a complication comes up. Some were concerned that they didn't have enough knowledge about how to make the prognosis and be sure about that prognosis of 6 months or less, or how to tell if the mental health condition was affecting the decision-making ultimately. Physicians were also concerned about privacy, both for themselves and for their patients and their family members. So even information about whether a physician is willing to make the prescription or not can be something that physicians feel is sensitive information and could make them vulnerable. Some physicians were concerned about the legal consequences and expressed that they generally didn't have a very good set of knowledge about what the law allows and doesn't allow. So some of the things specifically they were concerned about is if there are changes to the law, what will that mean for their prior participation in aid in dying? Others were concerned that if someone else in the family misused the drugs after a prescription was made, if they would be held legally liable for that. And some were concerned that if they moved to another state where aid in dying was not legal, if that would jeopardize their medical license. So they had questions about that and didn't always feel like they knew where to go to get answers to those questions. Some were also concerned about the professional consequences, including ostracism from their colleagues, whether they decided to participate or not, or sanctions from hospitals if their particular individual stance contradicted the stance of the hospitals they worked closely with. And then finally, some were concerned about problems in the process of aid in dying. So things like not being able to find a consulting physician to work with, not having the right medications available or those medications being very expensive, or not having an established process by which they were expected to communicate with patients. So not knowing how they're supposed to even talk about aid in dying as an option. So These concerns call for stronger implementation in practice as we move forward in California. So we've developed a few recommendations that we think will help improve knowledge and practice around aid in dying. So the first is that we think about the data collection that takes place around aid in dying. So we currently have required surveillance data collection, and this required surveillance is modeled after Oregon's Death with Dignity Act, and in many ways, that data has been helpful and has been used to evaluate whether that law is working as intended or not. But in California, there might be some adjustments that we consider. So first of all, we may consider changing the timing of some of the questions. So one example of this is that physicians are expected to report on why the patient has requested aid in dying. But the request for that information comes at that final form after the patient has already died. And so one recommendation we make is that that comes at a much earlier stage. That comes at the stage when the patient first makes the request so that it's a more accurate representation of what's happening in the patient's decision-making process. Additionally, there are many steps in this process, and the documentation only takes place at some of those steps, and we think it may be helpful to have more documentation at other steps. Of course, we have to balance that with concerns about privacy of the patients themselves and the burden on the physicians who already are filling out a lot of paperwork around these practices. But I think if we take a step back and start to think about exactly what we want to get out of these surveillance data, we might have a better approach to answering these questions. Finally, there may be other forms of data that we want to collect on patients that we don't currently, including things like disability status. So to evaluate that concern that people are made vulnerable by their disability status, we need to know how many people who are taking advantage of this law actually do have an underlying disability. We also recommend that we separate scientific inquiries from surveillance data collection. So as you may imagine, this is a very difficult topic to study. So because the number of people who take advantage of aid in dying is very small, it can be difficult to find those people. It's a really sensitive time in people's lives to be asking them questions about their decision making and their process. So it's difficult to have very high quality scientific studies on this topic. But we recommend that we continue to invest in this topic, and we continue to think about ways to creatively solve some of these methodological problems and not rely solely on the surveillance data that's currently being collected. Our second recommendation is to use the passing of the End-of-Life Option Act to improve end-of-life care generally. So one way to do that is to start documenting other types of end-of-life practices as well. So as we just discussed, aid in dying is under special scrutiny because of the law and because of concerns about vulnerability. But there are other things that happen at end of life that may help us to understand how and why people make the decisions they do and how they think about what's best for them at end of life. Some of those practices may include things like palliative sedation or patients' refusal of food and water. We know these things take place, but our estimates about how often they take place and how and why they take place and what that process looks like are just not very good because they're very hard to document. The more we know about how people make those decisions, the better we can orient care towards what is best for them and what they desire as they move forward. We also hope that aid in dying requests can be used as an opportunity to discuss a wide range of options. So we already know that in Oregon this takes place. We already know that there are more conversations taking place about end-of-life options. We know that when patients bring up a request for aid in dying, that physicians are more likely to spend time with people. And so in California, our recommendation is that we build this in intentionally, that we know this is something that could be a side effect and that provider organizations really start to think about the processes that will support that person-centered care. And then finally, one thing that came up in our discussions with experts on this topic is that once patients have made a decision to participate in aid in dying, they often are left without a lot of support, or their support comes primarily from hospice care instead of their primary care physician. And so one of the things that we recommend is that provider organizations start to think about how to provide continuous support from the moment that someone makes that first inquiry to the moment that they decide whether to ingest the medications or not, and through the final death, whether it's from the medications or not, and supporting the family through that process as well. So one of the things that came up is that in Oregon and in California as well, physicians are not required to be present during the death, even if someone ingests the medications. And if there are complications, or if that process takes longer than it's expected, or if the family members don't know what to expect, that can often be a very scary time for people. So providing that continuous support can be really beneficial to everyone. And then we also have recommendations related to education. So the general public does not have a very strong understanding of end-of-life options generally. They also don't have a very good understanding of aid in dying as a law. And so often people make assumptions about what is and is not permitted and what is and is not possible. And we believe that it would be helpful to bring more knowledge to the general public about end-of-life options. And this is actually especially important for aid in dying practice because the law is written to protect against making people feel coerced or under undue influence, but that means that the burden is on patients themselves to bring up aid in dying as an option. If they don't know it's an option, it's likely to be a conversation that never takes place. So when it comes to aid in dying, patients need to be more informed about what is possible than they are about other types of care. We also believe that state officials and regulators may benefit from additional education. So surveillance data is collected on a whole host of population and health-related information, but because the number of people who take advantage of aid in dying is so tiny, there may be special concerns about protecting the privacy of those data and being able to treat these data with care. And then finally, providers still have concerns and need continued education. So we went through what some of those concerns are. But in particular, communicating about end-of-life issues and helping providers to think through how to improve processes related to end-of-life care generally would be useful moving forward. So our group has continued to analyze these types of issues, but we're also interested in collecting original data. So I'll tell you a bit about what those data are and how we're moving forward, and then we'll have time for questions as well. So we have two main research activities that are currently taking place and will take place through 2016 and 2017. The first one is that we've designed a survey of physicians to assess their knowledge of the new law, their opinions about the law, and their comfort with aid in dying generally, their questions or concerns that they have about aid in dying, and we hope that we'll be able to use these data to inform educational efforts for physicians themselves. So currently we've designed the survey, it's ready to go. We'll be administering it to physicians at UCLA Medical Center very soon, and then we plan to expand it out to other health centers as well. So that's an ongoing project that we hope will improve practice as well as knowledge. Additionally, we're conducting group interviews with community members from different racial, ethnic, social class, and disability backgrounds. In these group interviews, we'll be asking about knowledge of the new law, reactions to aid in dying as a practice, concerns, and we'll also be talking to the groups about ways that we may improve communication about end of life generally for that particular group. We hope this will improve the cultural competency of providers as we start to pull together this information and be able to talk about some of the similarities and differences across groups, some of the assumptions that go into their decision-making processes about end-of-life communication and end-of-life options. But we also hope that it will help us to understand health disparities more generally. So as I mentioned earlier, those racial and ethnic disparities exist for all types of end-of-life care. So we hope this data will be helpful for that as well. So that is the end of what we have today. I'd like to again thank the End of Life Research Option Act Research Group, who's listed here, and then support from Thomas Weinberger, who allowed us to put together this group and put together this research we've been talking about today. Thank you.
Okay, so we're going to take questions. The way we do it is we take one from the people are here, then we do one online, and we go back and forth until we're all done. If we don't, we have more questions than we have time. You can also email me. Again, that's jdriscoll@ucla.edu, and I will forward on the questions to Cindy. And we promise we'll get back to everyone who has questions. So why don't we start with, is there a question in the room? Nadi?
Could you talk a little bit more about the mental health evaluation? Because presumably a lot of individuals that are at that stage where they would be thinking about even dying could be depressed along the spectrum of mild to moderate to severe, how do you determine, is there any guidance or is there any information on how do you determine when a person is able,
Right.
can go ahead or not?
Right. So the question was, when it comes to the mental health evaluation, how is it even possible to disentangle a process of grief over one's own death from depression processes, and are there any tools in place for that? And the answer is that that's one of the problems that's been identified in Oregon, is that it is very difficult to disentangle those, and that some providers have an expectation that people will have some level of depressive symptoms, and so when they try to use established tools like the PHQ-9, it just doesn't work, because if they gave it to everyone, they would score off the charts for everyone. And so they've started to try to find other ways to do it, but it hasn't really resulted in tools that seem to be working currently. Yeah.
Okay, so we have a question from online. Do you have a sense at present as to how many physicians will participate?
Mm-hmm.
And, I'm also wondering if there's any data from Oregon that shows how many physicians ultimately participated.
Mm-hmm. So that graphic early on about how many patients there were. So the question was if there are estimates on how many physicians will take part in Aid and Dying in California, and if we know anything about Oregon about number of physicians. And we do know about Oregon. And so that graphic early on about the number of patients who participated in Aid and Dying and how that's grown, there's a parallel growth in terms of physicians. So it started off with a small number of physicians, and that's grown with each year. But it's still, I want to say it's a few over 100 physicians who made all of the prescriptions in 2015. I believe that's what I read in the most recent report. And so it still is concentrated in a smaller proportion of the total number of physicians who could be participating. I would expect that would also be true in California. It will be interesting to see as we move forward which provider organizations take stands and which provider organizations leave it open to individual providers to make those decisions themselves. But I expect it still will be the case that the vast majority of prescriptions will come from a smaller number of providers.
Is there a question?
Hi.
So there's a whole population of people that usually aren't looked at in these studies, which is the people that don't ask for a prescription and never benefit directly from these laws, but might be psychologically benefited by knowing that possibility exists if they ever find that determine that their situation gets too bad.
Right.
And have there been any studies of the Oregon population or other populations as to try to measure benefits to people that of just knowing that the law is there?
Yeah, that's a great question. So the question is, there are people who benefit directly from Aid and Dying laws because they request and receive and use a medication or opt not to receive the medication, but that there may be a more general improvement because everyone knows that it could be an option. There's a kind of psychological improvement from that process. And I don't know of any research in Oregon that has documented that, but that was early on one of the things that most interested me about this particular project, was that there was an opportunity to see if that kind of culture shift that comes from a change in the law would actually shift end-of-life care in a more general way, so that more people thought about these options, more people had conversations with their loved ones about what they wanted at the end of life, more people would start filling out advanced care directives or things like that to make sure everyone else knew what their wishes were at end of life. And so as we move forward, that would be something I would really like to build into this research, is to think about what the larger implications are for the population as a whole.
We're having quite a spirited online discussion.
Oh, great.
Which I'll catch up on, Cindy. But basically, I guess the next question is, do we have any sense, we asked about doctors, do we have any sense of, is there an estimate of how many Californians will actually request these prescriptions in coming years?
So Sarah and I were just talking about this yesterday. There was an estimate, do you remember what the number was? About 400 patients on Medi-Cal, expected patients in the first year. So the question was, do we have an estimate of how many people in California will be trying to take advantage of the Aid and Dying law? And so there have been estimates done to estimate how much money should be set aside through Medi-Cal. So Medi-Cal will pay for these prescriptions. And they estimated about 400 people who are served by Medi-Cal in the first year. So if that's similar to Oregon in terms of how many people of the population are served by Medi-Cal versus private insurance, that maybe is about half. I've seen a range of estimates in total, but it's hard to extrapolate from Oregon data exactly what those numbers will look like because the population of California is fairly different than the population of Oregon.
I'm a little concerned with when you can no longer as a person do it. For example, you have a stroke, and I wonder if any of the states currently have, or closer to the point, where you could, like a power of attorney, and say, you know, if I'm in this kind of state, I will. Is there anything like that available yet?
And Cindy, there's a similar question online about Alzheimer's patients.
Sure. Okay. So the question is for patients who no longer are able to self-administer the drugs, or for patients who have dementia or other forms of cognitive decline, if there are other options for them in any of the states. And the answer is for Oregon, Washington, California, and Vermont, no. It is built into the law that they must be able to self-administer the drugs. They must be able to swallow, which can also be a problem for people at the end of life. And if they have any sort of cognitive decline that is going to impair their decision making, then no, they would be declared not able to make that decision for themselves. And no power of attorney or surrogate or any other person can make that decision. So currently, no. Now, when it comes to Montana, because it was passed through this other legal option, it's much more open. And there have been reports in Montana that there have been other ways that people have went about this process. But like I said, we don't have very good data about that, so they've been more anecdotal than factual data. Yeah.
So I am trying to sort out whether this is a question or not, or we're just having a great online discussion. But
Great.
There's a comment about palliative care, how when Oregon passed the law, it was in its infancy, but in California, the palliative care movement is well established and underway. I guess the question is, do you expect that to have a significant effect on prescription usage?
Yeah, so the question is, when Oregon first passed the Death with Dignity Act, palliative care was still in its infancy. The comment was that in California, palliative care is more advanced, and will there be a different kind of effect on palliative care in California than Oregon because of that difference? I think one thing to point out is that when we talk about palliative care, we often are not talking about the same thing across different conversations. So in the U.S., hospice is the primary means by which people get palliative care. But hospice is really relegated to the last 6 months of life for people. Palliative care also can take place at any other life stage, so it doesn't have to be end of life. And so when we say that in Oregon that palliative care was still in its infancy, that may be true if you're just talking about palliative care as it's separate from hospice care, but hospice care was long established in Oregon before the Death with Dignity Act and grew to become stronger through that time period. So I think when we look at California, we'll see something very similar, which is that, and it's not necessarily the passing of the End-of-Life Option Act, but it's just growing interest in these types of end-of-life options that I think we'll continue to see more support for hospice and palliative care, and I hope that we'll see more creative ways of putting together palliative care with even curative efforts or things not aimed at just the end of life.
In your data collection, do you look at a person's religion or religious beliefs?
Mm-hmm.
And do you think there'll be a backlash from pro-life kind of groups?
Yeah, so the question was, will we be collecting data on religion or religious beliefs, and if there will be a backlash from different religious groups? And absolutely, the strongest opponents have, from the beginning, been different religious groups. And in California, the Catholic associations were able to block every other attempt at any sort of end-of-life option. So yes, that's a really good point. In all of the research on physicians, one of the best predictors on whether a physician will oppose any sort of aid in dying is the religion and level of religiosity. So those are all things that have been collected before. We will be collecting those data as well in our survey, and then in our focus groups, we'll also be integrating some questions about religion and how religion factors into people's decision making. So it absolutely is a critical point for thinking about the general public as well as providers themselves and how they're approaching these questions.
And Cindy, there is an online comment about Catholic hospitals, Orthodox doctors, and how that might affect whether physicians believe in provide the information or not.
Right. So the question was for Catholic hospitals or for Jewish Orthodox hospitals, if that will affect the decision making and the providers who are available. And yes, the answer there is yes. Most Catholic hospitals have said that they will not be taking part in aid in dying, which means that the doctors who work within those hospitals will not be able to do it while they're on the premises and employed by the hospital. And if they have some sort of admitting privileges but are not technically employed by the hospital, they may not be prohibited from participating, but there have been reports already that several physicians have decided to stay out of it because they don't want to affect their relationships with those hospitals.
So there's questions about, will this prescription be covered by Medi-Cal? What about Medicare, federal program? And I think it's a broader question of who's going to cover this prescription?
Yeah, so the question is, who will pay for aid in dying prescriptions? No federal funds can be used for aid in dying. So what that means is that Medicare does not pay for it. Medi-Cal will pay for it, but only because they're taking all of those funds from the state side of things, not from the federal side. And then individual insurers will make the decision themselves on whether they will pay for it or not. There are some rules there in terms of the insurers, though. So if you have a terminal illness and you call your health insurance company, they can't say to you, hey, you have this option. You would have to say to them, I heard I may have this option. Can you tell me if it's covered? So there are rules there to prevent any sort of coercion. And then health insurers are also not permitted to discontinue curative treatments while simultaneously offering aid in dying. So they can't tell you we won't help you heal, but we will let you die. So those are the rules.
Another question from Ying. I'm sorry, did you have a question?
Yeah. Do you know what are the primary diagnoses some people requested?
So the question is, what are the primary diagnoses? They are mostly cancer of a various different range. I have the report here from Oregon, so I can give you exact details, but it's a little over half are cancer diagnoses.
Sorry, we got a lot of questions. We're not going to be able to get to them all, but let me just take a few more. Will any of your research questions in the first year be geared towards the concern about patients being pressured to pursue aid for financial reasons by insurance or family? Are you recommending that the state collect income information from participants?
So the question was, will we be speaking to questions about income vulnerability, if we think the state should be collecting income data, and if we'll start to explore whether people are taking this option for financial reasons. In the focus groups, we've left it open to talk about things like family influence, to talk about how finances may come into it. We don't have any specific questions about it because we would like for these community groups to speak more from their own interpretation instead of having us kind of feed them what we think the concerns might be. As we move forward, we hope to be able to develop a wider quantitative survey of the general public and their questions and attitudes and concerns. In that, I think we'll be able to ask more questions about end-of-life experiences generally and how much people perceive that they might have a financial incentive or there might be a financial reason to consider these types of options. You know, as I said earlier, this is a very difficult topic to study. Whenever you try to understand what someone's motivation is for making a decision that they already feel sort of stigmatized about making, like to participate in aid in dying, it can be really touchy to get that kind of information from people. So we want to be sensitive, we want to get good data, we want to be able to speak to those concerns, but we don't want to make people uncomfortable through this kind of analysis. As to if the state should be collecting income data, in most social science research, education works as a good enough proxy for income. I think for right now, that's probably as far as the state would be willing to go. Yeah.
So I have a question, which is
Great.
The placing of the burden of finding out about this on the patient seems to me unworkable over the long term. Has there been in any of the states any talk of creating sort of a registry of doctors who are willing to do this, that patients could find online, that they could apply to through a confidential process, something like that, where you don't have to like call 6 different doctors to figure out who can do this, or that it even exists?
So the question is, the way the law is written, it puts the burden on the patients themselves to know about these things and then ask doctors about it. And then if their first doctor says no or doesn't provide them that information, they might have to keep asking around if there will be registries or any other sort of information available. California is trying to set up a hotline that would be available for people to call in and ask any sort of questions they have. I'm not sure if that will include information about which doctors participate or not. I think they're still trying to work out those details and weigh the pros and cons of having that information available. But I do know that there are other organizations that are not run through the state. So Care and Compassion is Compassion and Choices, is one of those organizations, and we have a couple of their representatives here. And so they provide information for people as well if they have questions or they want to know who else they might go and speak to. So there are several different organizations that are trying to fill in those gaps. What can sometimes become difficult is that because that information is not provided by the state, there isn't necessarily any sort of quality control on the types of information that's going out. So, I believe that there's a good reason for California to set up the hotline. I think that would be really helpful to people. But you still have the case that people would have to know that they're interested to know that they should seek out the hotline. So that's where the public educational campaign comes in. We have to raise awareness generally about this option. Yeah.
I'm Patricia Portillo with Compassionate Choices. We released a video this week that educates Californians of how the law works. So I have shared that link with you. But it's something, it's also on the Compassionate Choices Facebook page, and we're distributing it all over the state.
Great. So the comment is, in terms of public education, that Compassionate Choices has put together a video that educates Californians about the law.
We'll have one for doctors coming up on June 9th.
Okay, great.
Any other questions from Mr. Sullivan?
I would just add, I'm Paul Bush, also with Compassionate Choices, that now that the act has been put into place and signed by the governor, Compassionate Choices has switched to an access campaign, and we are actively out trying to do outreach both to the public and to the medical community to educate them about the law and what's available, and to make the conversation a more normalized one.
Yeah, so the comment is that these videos maybe are just the beginning of a larger campaign to continue having these conversations and to normalize having these conversations instead of only having them in moments of crisis.
Or urge Californians to talk to their doctors now, even though they're not terminally ill. Speak to them of what they would like at the end of life.
That's a good point. One of the recommendations generally has been for people to talk to their doctors even before they have a terminal illness, to ask what their doctor's opinions are of these practices and to make their decisions if that's something that's important to them.
Well, we're really at time, so I want to thank Cindy. And Cindy, I've told the online folks that if they have further questions, email me. I'll pass those questions on. Likewise, you guys have my email address, so please, if you have additional questions. It's a very controversial, very interesting debate. We're going to be doing more research on it, so please contact us. But thank you very much, Cindy.
Thank you.